Hello, my name is Sean Vong, and I'm a PGY5 in neurosurgery. This presentation is the beginnings of experimental hydrocephalus, and this is a presentation for the Society into Research of Hydrocephalus and Spina Bifida, and I'll be presenting this at a meeting later this month. I have no disclosures. So what is hydrocephalus? According to the NIH, hydrocephalus is a condition which the primary characteristics is excessive accumulation of fluid in the brain. This is a pretty good starting definition, but it includes some things that aren't really hydrocephalus, and it excludes some things that neurosurgeons would definitely treat as hydrocephalus. So in these definitions, for example, in the one in particular that we just saw with the NIH, accumulation of fluid also includes something called hydrocephalus ex vacuo, which, although the name has hydrocephalus in it, it is an enlargement of the ventricles because of loss of parenchyma and loss of tissue. So it's an artifact of the loss of the brain tissue, and so you see an enlargement of the ventricles and an accumulation of fluid. Some definitions of hydrocephalus include increased pressure. This would exclude things like normal pressure hydrocephalus or low pressure hydrocephalus. And then other definitions include enlarged ventricles, which would exclude things like slit ventricle syndrome or benign external hydrocephalus. So unfortunately, different groups have realized that a rigorous definition of hydrocephalus is surprisingly difficult. And I think that as we learn more about hydrocephalus, it's beginning more complex. So what is the classical understanding of hydrocephalus? Current understanding is pretty much shown in this picture here. You can see the normal circulation of CSF per the bulk flow theory. And then there can be this buildup on the right due to either an increase in CSF production, a decrease in its absorption, or increased pressures. Because of those three things, neurosurgeons usually look at hydrocephalus as a plumbing issue, and as a result, we try to bypass or augment the normal absorption in the brain by passing something like a ventricular catheter into the brain and then bypassing the normal absorptive center and allowing the CSF to drain into the peritoneal cavity where it's absorbed. So the basis of these theories pretty much comes from all the work from Dr. Dandy. He kind of started this foundation. And this is the classical CSF model that we teach all medical students. The CSF is created in the choroid plexus, and then it enters into the lateral ventricles, through the foramen of Monro, where it passes into the third ventricle, down the aqueduct, and then into the fourth ventricle. Then after that, it leaves the ventricular system and goes into the subarachnoid space, where it's absorbed into the arachnoid granulations, or the arachnoid villi. So Walter Dandy graduated from Hopkins in 1910, became house staff there in 1911, and then started studying hydrocephalus under the father of neurosurgery, Dr. Cushing, and Dr. Halstead. He produced this manuscript in 1913 with Dr. Blackvan, and essentially this was a canine model in which they did a surgery to produce an obstructive hydrocephalus by inserting cotton into the aqueductus sylvius. The dogs, after 3 weeks, developed lethargy and vomiting, and they did develop what they were calling internal hydrocephalus at the time. But of course, the obvious problem with this is that the surgery could be causing those symptoms. Here's an illustration from the paper showing a control animal on the left, and on the right, an experimental animal with the ventriculomegaly and the obstruction. Based on these findings, Dandy and Blackvan concluded that the absorptive capacity of these animals has to be much less than the secretion, and that's how you're getting the ventriculomegaly. To continue this, he did phenol red injections and 2 hours of monitoring. When he injected the phenol red into the lateral ventricles, he noted that there was less than 1% of it excreted in the urine. But when it was placed in the subarachnoid space, particularly the cisterna magna, he noted a 35 to 60% excretion in the urine. And so he concluded from that most of the CSF absorption has to be happening somewhere in the subarachnoid space and not within the ventricular system. He noted at that time very little dye in the thoracic lymphatic duct and also concluded that it must not be going through the normal lymphatic channels. So the primary theories at the time was that there was 3 ways in which CSF could enter the venous sinuses, either through stoma, through arachnoid granulations or arachnoid villi, or through some kind of general osmosis. So he injects fine granules, he never really describes what those are, and notes that there's not really any granulations noted in the sinuses of these animals. So he says that there must not be stoma. However, it does accumulate towards the superior sagittal sinus, so it could be the arachnoid granulations or it could be osmosis. He also concludes that the choroid plexus, given previous histology papers, and in his experimental model, where he blocks the aqueduct and you see ventriculomegaly, that the choroid plexus has to be where CSF is formed. He also describes 2 types of hydrocephalus that we currently still use this classification today. Type 1, or the obstructive hydrocephalus, where there's some kind of obstruction in the ventricular system. And then type 2, a communicating hydrocephalus, where there's no obstruction in the ventricular system, allowing communication with the subarachnoid space, and yet there's still hydrocephalus. To follow that up, in 1919, he came up with a second manuscript, kind of continuing his experiments. And so there was in this one, he blocked the foramen of Monroe, then did a block with a choroid plexus removal. Choroid plexus removal was blocking the aqueduct, and then a basal cistern blockage. So here's a picture of or an illustration here showing how they went about doing the surgery to block the foramen Monroe, and then a picture showing histology cuts, a gross specimen showing the ventriculomegaly right here on the side that the foramen was blocked. Another gross specimen, in this one, the foramen was blocked on this side and choroid plexus was removed, and he did not see ventriculomegaly, again concluding that the choroid plexus has to be the site of secretion. Here is a illustration of how the ventricles looked like in a gross specimen after near complete choroid plexus removal and then blockage of the aqueduct. Also in this manuscript, he tried to show how CSF flowed, and how he did that was he would inject India ink and phenol red into the ventricles, and then sacrifice the animals at different time points and try to see how far the India ink distributed, and then use that as a way of determining how the CSF flowed. Here's an illustration of how he did his basilar cistern blockage, trying to create a communicating hydrocephalus model similar to what we see in post-meningitis patients. And he did end up with some pretty substantial results in large ventriculomegaly. Also some more drawings from his paper, just revealing that the India ink was able to spread unless he did his banding procedure, which created an obstructive hydrocephalus essentially at the basal cisterns, and a dorsal view of that. So to conclude Dr. Dandy's work, this essentially was the foundation of the current theory of CSF dynamics. He was questioning arachnoid granulations at the time, particularly because the phenol red, he felt that measuring that in the urine, even with the cranial cavity separated from the spinal cavity, he was able to see that with phenol red injections just in the spinal cavity, there was still a pretty substantial measurement of the phenol red in the urine. And so he concluded from that maybe the arachnoid granulations are not the spot that CSF is absorbed. So he suggested that maybe it's just generally absorbed everywhere. One of the criticisms of a lot of Dandy's work is he wasn't able to measure the pressure at that time, so it's hard to say whether or not he achieved a complete obstruction and how the pressures went up in those areas. And then he offered no theories on congenital hydrocephalus. To continue that, at the same time, Dr. Lewis H. Weed was working on his research at Harvard in 1914 and produced one of many manuscripts. This was one of his manuscripts on just how the arachnoid villi played a role in the cerebral spinal fluid. he made 4 conclusions of this, which are the 4 next slides. Essentially, one, that after slow injections of Prussian blue, he noted that there was granules within the arachnoid villi, and then so he concludes that the chief method that CSF is absorbed into the general circulation is through the arachnoid villi, which is different than what Dandy's conclusion was. Conclusion 2, that the arachnoid villi are not the only system, but they are the major draining system of CSF. And there is an accessory system that goes through the lymphatic pathway, but maybe he provided a theory that maybe it went through the cranial nerves down and then got absorbed into the lymph in the neck and then ended up in the lymphatic system, thus being kind of an accessory system that didn't really play a major role. His third conclusion was that none of the CSF is absorbed into the cerebral veins or capillaries, because when he did the Prussian blue or carbon granules injected into the subarachnoid space, after sacrificing those animals and doing histology, he did not note any Prussian blue granules or carbon granules in the actual artery or in the actual cerebral veins. And lastly, he concluded that the absorption from the cranial space is much more than the spinal portion. And he did that very similar to Dandy's work. He separated the cranial space from the spinal space at the lower cervical junction, and then injected potassium ferrocyanide, and then tried to detect it in the urine. And he noted that 20 minutes, he was able to detect pretty substantial amounts of the potassium ferrocyanide in the urine, but when injected in the cranial cavity, versus 75 minutes in very trace amounts when injected into the spinal cavity. So from both of their work, Dr. Harvey Cushing in 1925 delivered a lecture called The Third Circulation. And I think this really hammered home and cemented in how we understand and how we still base CSF dynamics today. So to conclude, that CSF circulation and hydrocephalus is still based on theories 100 years old. However, there are new theories that are based on clinical and experimental observations that are coming out that question the old theories that were produced by Dr. Dandy, Dr. Weed, and Dr. Cushing. So this is an exciting time to be researching hydrocephalus. Thank you.